I am Dr. Varun Chawla. I'm a nephrologist in private practice and I practice in the San Francisco Bay Area. What I'll be talking about is two interesting Alport syndrome cases that we identified using the Renasite test recently. So let's start. So the first case is a 49-year-old male that I initially saw in 2015 for the evaluation of chronic kidney disease and proteinuria. He had a past medical history of melanoma, basal cell skin cancers, and hypertension. About his family history, his father had died in his 50s with lung cancer, mother died of uterine cancer at a young age, his younger brother was on dialysis, and his maternal aunt was also on dialysis. So his initial workup showed that his creatinine was about 1.4. His urine analysis and sediment showed that he had microscopic hematuria, and many of his RBCs were dysmorphic. His urine protein creatinine ratio was about 0.4 gram per gram. When we did a urine protein and serum protein electrophoresis, it showed that he had an IgM monoclonal paraprotein band. Given the IgM monoclonal paraprotein band, he was referred to hematology. Hematology decided to do a bone marrow biopsy, which was consistent with a B-cell non-Hodgkin's lymphoma. Subsequently, he had a PET CT, which showed no extraosseous evidence of lymphoma. So from his kidney standpoint, we thought that his chronic kidney disease may or may not be related to his non-Hodgkin's lymphoma. But because he was going to get treated for the non-Hodgkin's lymphoma, we decided to defer his kidney biopsy. So for his non-Hodgkin's lymphoma, he received treatment with rituximab and cytoxan for 6 cycles. After that, if you look at his creatinine trend, his creatinine remained pretty stable in between 1.4 and 1.45. However, his urine protein creatinine ratio, his proteinuria, kept on increasing. Now, during this time, after treatment, his IgM levels were less than 800 milligrams per deciliter, and he had a normal serum viscosity, and his repeat PET scan showed no evidence of any disease. So just from a pure hematological perspective, he seemed to be in remission for his non-Hodgkin's lymphoma. Now, given that his proteinuria had increased, at that time, we were unsure if his chronic kidney disease was related to his lymphoma or not. Thus, we decided to do a kidney biopsy. The kidney biopsy was done in 2016, and it showed that he had a podocyte foot process effacement and segmental thinning of his glomerular basement membrane. There was also suggestion of lamelation in certain foci on electron microscopy. Given the foot process effacement and thinning of the GBM, it was felt that he had likely minimal change disease FSGS spectra related to his lymphoma. Now, given that he had segmental thinning of his GBM, it was, we did consider him having Alport syndrome, but it was ruled out because the staining for alpha-3 and alpha-5 collagen type 4 change on immunofluorescence was negative. Given that he had a lymphoma-related process, despite his IgM levels being low and his serum viscosity being in the normal range, it was decided in conjunction with hematology to start him on a tyrosine kinase inhibitor. So he was started on ibrutinib, and he was started on ibrutinib in mid-2016. The patient did not tolerate the tyrosine kinase inhibitor very well, and he needed several dose adjustments. Now, he remained on tyrosine kinase inhibitor, but his creatinine continued to rise. And in 2019, we decided to get a second opinion from a tertiary center. So he was sent to UCSF. At UCSF, they re-reviewed his 2016 biopsy. And what they concluded was that the patient likely had secondary FSGS due to hypertension. Also, given the features on his electron microscopy of segmental thinning of his basement membrane and possible lamellation, it was thought that he could possibly have Alports. But it was felt that though genetic testing could be interesting, but given the paucity of commercially available testing at that time and the fact that it was unlikely to change his management, no genetic testing was done at that time. Now in 2020, when Renasight came out, I decided to get him tested. So when we did the Renasight test, what we found was that he did indeed have Alport syndrome. So he was found to have a hemizygous pathogenic variant in the COL4A5 gene. So we confirmed that he did have Alport syndrome. So now how could have the genetic test helped us? So if he did have, say, Renasight in 2016, at the time when we did the kidney biopsy, he probably did not need chemotherapy, which he got from 2016 till early 2020. Also, he had microscopic hematuria, for which he had a urological evaluation. He had a cystoscopy and 2 CT scans. If we knew that he had Alports at that time, he probably did not need the cystoscopy and the 2 CT scans. And after we got the Renasight test, it did change his clinical management because his chemotherapy was stopped. We reclassified his clinical diagnosis, and we're currently pursuing clinical trial for Alport syndrome for him. So this diagnosis of Alport syndrome that we made using Renasight test indeed changed his clinical management. Let's go on to case number 2. So case number 2 is a patient that I saw recently. He is a 22-year-old male who had come to me for evaluation of chronic kidney disease stage 4. He had a past medical history of IgA nephropathy. When he was 16 years of age, he had a kidney biopsy done at Children's Hospital in Oakland and was found to have IgA nephropathy. At that time, he was started on prednisone and lisinopril. The prednisone was stopped at the age of 18, and the lisinopril was stopped when he was 21. So when he presented to me, I checked his labs, and his lab showed that his creatinine was about 1.99. So his GFR was close to 45. His urine showed 2+ protein and 2+ PAR. We did a kidney biopsy on him, and what we found in the kidney biopsy was that his light microscopy showed that he had 60% global glomerulosclerosis and 40% interstitial fibrosis and tubular atrophy. The immunofluorescence surprisingly just showed minimal mesangial IgA deposits. The electron microscopy showed that his basement membrane was segmentally thickened. So the differential diagnosis of the biopsy was, he could have sclerosing IgA. However, the lack of significant IgA deposition in this case made me very suspicious that he had another process. He could have a familial FSGS, type 4 collagen disease, or secondary FSGS. As we were not sure of the diagnosis, we decided to get Renasight testing done for him. So what we found was that he indeed had Alport syndrome. What we also found was that he had another genetic abnormality, or he had ovelocytosis. So the Renasight confirmed that he had Alport syndrome. Now, the Renasight really helped us. First, given his young age, we are looking to enroll him in clinical trial. Second, we are also going to evaluate all his family members for Alport syndrome. And number 3, he's very young, he's 22, and at some point he would be looking to start his family. And this diagnosis of Alport probably would come into play as he plans his family. So again, the Renasite test in his case really changed his clinical outcome. So thank you for your time.